coming today and making effort to cover the Museum of Liverpool. It is my absolute pleasure to introduce this inimitable panel on to discuss the future of the NHS. We have Claire Ainsley with us, who is the Director of the Project on Central Left Renewal at the Progressive Policy Institute, and is also the former Director of Policy for Keir Starmer. We have Zubir Ahmed, who, as well as being an MP and the PPS to the Secretary of State for Health and Social Care, is also a consultant transplant and vascular surgeon. I've got that correct, right? And to add to the further list of clinicians we have on the panel, we also have Dr. Sonia Adesara, who is a GP, but also is the interim chair of the Fabian Society, and then Stephen Bush, who, what he lacks in clinical expertise makes up for in political expertise, is a columnist and associate editor at the Financial Times. So I'm really looking forward to this panel. I think at Reform we really believe that the post-war public services settlement is fundamentally no longer fit for purpose. And in its early years, the NHS was visionary and inspired healthcare systems across the world. But 3/4 of a century later, demand is increasing and outcomes are deteriorating. The current model no longer works for patients who can't access high quality timely care when they need it. It no longer works for staff who are overworked and stressed, and for taxpayers who are having to foot an increasing bill for a service that no longer quite meets their needs. So many people say a bold and urgent rethink is needed, and for many people that was the shift to prevention. Sadly, after 30 years, this also has not really materialised. But it's not all bleak. At Reform, we do specialise in, believe it or not, reform. So I believe on this panel we will hopefully focus on lots of interesting ideas for the future of the NHS. So I will now pass over to Claire Ainsley, well, to the panel, all of the panel for their remarks, but first up for Claire Ainsley on her thoughts.
Okay, great, thank you very much. That's okay. Yeah, and I'll probably be referring more to my UK experience than my US experience in terms of the kind of context for this panel. Thank you very much for hosting this, and I think the focus on reform is absolutely right, and I'm sure there's been like a healthy dialogue about the tension between reform and funding. They're not different things, they are one and the same, I think, and I'm sure we'll get onto that. In sense, the condition of the NHS, I think, is a symptom, not the cause of the nation's poor health, and the nation is in poor health. It just seems at a time when we've never had more access to knowledge, to science, incredible developments on technology, diagnostics, and so on. Our understanding of the human body and brain is, at such a kind of level, but our nation's health is in such bad condition. Like, we have to just reflect on why that is and why we're accelerating in some areas, and we've not kind of popularised that in terms of the health of the nation. The workforce, I don't want to speak too much about the workforce because we have parts of the workforce with us, but the workforce being in such a kind of bad condition in the sense of the way that they've been treated, and I think it's a national shame that we went into the pandemic so poorly prepared, but I also think it's a national shame that we didn't, when we had the opportunity, really work through what the recovery was going to look like for the workforce. And I don't come from an NHS background, but I'm never going to forget during the pandemic the testimony that we were getting from the workforce about what was happening to them and to their patients. And you felt that sort of helplessness of seeing what they were going through on all of our behalves and how we have treated them since. And I think the idea that we somehow don't know why there are lots of people who are leaving the workforce, why mental health and physical health is in such bad condition, when all of that was confronted with us. There could be no politician anywhere or party that says they didn't know what was going on. Like, that was absolutely clear. We absolutely should have had a workforce strategy from the start. We now have one. It is somewhat late, but we absolutely should have had that capacity for the workforce to recover. So I think we went into the pandemic poorly prepared, but we also, I think, have not done what we needed to do to learn the lessons very quickly from that and recover as we rebuilt the nation. So I think for me the question is the goal is a healthier nation, and the question I would like to ask is what contribution then to a healthier nation does the NHS play, rather than necessarily thinking about how we fix the NHS. It's how do we have a healthy nation, and what contribution does this modern NHS that we want to rebuild look like. And like you're going to hear, I imagine we're not going to say loads of different things, but I think the start of that has to be about focusing on public health and preventable disease. Like the fact that we have got so many diseases now that are absolutely preventable is just mind-boggling. That as a species we could stop this stuff, and we actively choose not to. So we have got the technology and the know-how. Tackling health inequalities, like it. How can we be at a point where we know what is driving ill health in so many areas? We actually know what some of the answers to some of this stuff is, but we haven't grasped the tools to do it. And integrating local approaches to health alongside the kind of society that keeps people well. And this stuff is the bit that kind of isn't the sort of like hard policy or the technology, and is probably less well articulated, but Keir did start to articulate some of this actually at the Fabians about 3 years ago. He did a big speech on health prevention, which I was very involved with, and he started to talk about the kind of society where we would be encouraged to live healthier lives. And there was a bit about smoking, but most of it was actually about how we felt purposeful, productive. We lived in places that were cleaner, greener, where we can contribute, where we had social approaches to loneliness, all the sorts of things that way before we present ourselves to accident and emergency, we could be doing things about, things that make us feel good, keep well, the stuff that we do for ourselves as well. So talking about that, I think that is at the core of much of that. So what our societal approach I think is really important. There are, I think, really good public policy that is trying to pin some of this down. So I think part of what Greater Manchester has done on sort of social prescribing, some of this is well known to the health service, giving local public authorities much more access to their population's data. Like this is all doable stuff. Like why is it that if you go online, you can absolutely be targeted with exactly what it is. I've been looking up clothes, sofas, or whatever I'm purchasing, but you go to the GP and they don't have access to the same type of data. Like it is absolute travesty that we have the technological know-how, but we haven't applied that to the thing that matters to us most, which is keeping well and healthy. I also just think, there is a bit of a focus on smoking at the moment, but I just think food and obesity and our sources of locally, sustainably produced food, and how we're approaching some of those public health measures that do need the government to act. They are not things that you can just say to people, actually, no, you should be having healthier food. It absolutely has to be something that is regulated, so we knock out that bottom, that poor practice at the bottom end. And of course, something Wes has been really keen on, which is how we can use technology. And obviously some of that is what happens in hospitals, but some of that's about these things and the things we do ourselves, and being a bit open-minded to the fact that some of this is coming from the innovation of the private sector, and that is not about a gateway of privatisation. It's about the fact that we do things in our private lives to keep ourselves well. Why not integrate some of this stuff and have those sorts of goals? Go with the grain of how people want to live their lives, which is healthier and better where they can, and make sure we can then really target interventions when people are sick and unwell and they need that support, because at the moment we are mixing up and muddling all of those things. So I think to get to be a healthier nation, we have to think about the kind of non-NHS measures to improve our health, and then what contribution does the NHS make and how. So I totally support, obviously, the government's direction of travel that they've set out, the shift to prevention, the shift from acute care to community, mobilising new technology, this openness to integrating with the private sector where we can. Personally, I prefer the carrot approach to the stick approach on some of the individual behaviour change. I think we can't go for a model in economic policy which treats people as if they are always acting in economically self-interested ways, and then have a model that doesn't go with the grain of how people actually want to live their lives. But let's talk about that. I'm also very comfortable with us hammering down on corporates where they're exploiting people, particularly their vulnerability, so particularly the food industry, but not only. I think this shift from central to local decision making is really, really important, and I think it's probably one of the most, don't use the word radical very lightly or very often, but I do think it is one of the most radical pieces of Labour's policy around what it intends to do is its plans on devolution. So I think we saw in the pandemic this complete jarring between the centre and local places. A lot of the know-how and the intel was in those local places, and they were hungry for that information and responsibility. So I think that has got to be part of it. And I think you can see where you've got an anti-Burnham, you can see where you've got responsibility for your economic policy, for jobs, skills, health and social policy. It does encourage this community-based approach. You need central government to do some of the kind of regulation and the framework and the funding, but you absolutely need to evolve. So when the funding does come, it has to come. Like, the reason why Labour have dialed up reform is not because they don't want to fund the NHS, it's because all we then hear is the funding bit without the reform bit. I think I want it to be on the things that are going to drive reform, not just on immediate need, and I think that's going to entail some really kind of difficult debates about what do you invest in now in order to drive better health in the longer term, not how do we do the sticking plaster stuff, because we're going to need the sticking plaster too. I think that's what we are about to confront as we go into this winter. I would say that the workforce and settling those pay disputes, I think, is a good strategic choice. You do need a workforce that's been treated better than it has done over the last few years, but it is also going to need the workforce to lead some of that change, and I'm sure that's where other colleagues on the panel will want to have lots to say on too.
Great, thanks so much, Claire. So that was an interesting focus on prevention. Zubir, do you want to come in with your opening remarks, particularly with some reflections on the acute sector?
Yeah, but thank you very much. I think, obviously, what resonates from what Claire said to me is about who's responsible for the health of the nation, and it's not the NHS, it's all of us, it's government, it's individuals, obviously, other third sector organisations. And there's a recognition, I think, over the last few weeks, particularly with the Darcy report, that of course we knew the system was sick, but now we know that people are also sicker and they're more complex. And the system we have to support them is simply inadequate. And if we have to look at it from a patient-facing perspective and a pathway-facing perspective and ask the question, what we're doing right now, is it working? And is pouring money into that going to make it any better from a patient outcome perspective? And the answer, I think, is we'll all pretty much agreed is no. So that's the what, then it comes to the how. And you'll know about our three kind of paradigm shifts that we want to create in the health of the nation. I wouldn't call it an NHS, I would call it the health of the nation. So it's shifting it from hospital to community. The analog to digital thing is really important. To me personally, it's obviously about AI and diagnostics and robots doing wonderful things, but actually from a clinical perspective, a clinician perspective, it's actually about doing the processes better and in a more automated fashion. So we release those doctors and nurses back to you, the people, rather than them being buried under paperwork and in front of screens or computers that don't turn on for 15 minutes. So it's actually the analog to digital and then back to the analog again, because that frees up the individual to do the human part of a job that at the end of the day, that's what patients and the public still demand. They demand a human interaction at the end of that digital process. And then of course, thirdly, it's about pivoting away from treating people at the end stage of the condition to preventing it in the first place. And we all know about the obesity pandemic, the pandemic that's hitting us worldwide in developed countries and now developing countries. And there are elegant solutions for that, pharmacological solutions, surgical solutions, population health solutions, they're all out there. In some parts of the world that actually are successful in reversing the obesity trends. And I think that will become more apparent over the next couple of years actually, where people have been successful in doing that. We all know we have a national health service, but we don't have a universal health service in the sense that more and more variation in practice and outcomes has crept into our country, particularly the last 10 years. In some areas of Glasgow, life expectancy from one end of the street to the other end of the street is a 15-year difference, and that's widening. When you go into a hospital, you can have excellent care if you're having a stroke or a heart attack, or as Lord Darcy adumbrated in his report, it can be very, very poor, and that's directly related to your outcome, your short-term outcome as to whether you survive or not, but also your long-term outcome as to what morbidity that has inflicted upon you. So I think you know, we can get very downbeat about the National Health Service, that it's broken, it's X, Y, and Z, but actually, fundamentally within that, in individual organisations, there are really, really good exemplars of good, excellent, high quality, world leading practice. So we've got to bring that best of the NHS to the rest of the NHS. And I think that's what makes me most optimistic about this whole thing, is that the tools and the substrate for change and reform are already here. We in government just have to instrumentalise them and provide the narrative for them. And in many cases, clinical leaders need to be unburdened of the day-to-day responsibilities so they can have the thinking time, the headspace to come to the fore and make that contribution. And that, I think you will see that as our 10-year plan for the National Health Service germinates, because it's going to be a proper bottom-up approach with patients, with junior doctors, with senior doctors, with allied health professionals, with people outside the health service upon whom the health service really relies and upon whom the health service impacts on their day-to-day functions, whether it's in social care, third sector, local government. Because if we don't start to develop those kind of interconnectivities, we will never solve this issue. And that's what inspires me most about the mission-led approach, because it transcends the natural borders of, you know, governmental organisations, and it forces people and facilitates people from different government departments into the same room on a regular basis for face-to-face contact and time and development of strategy. And I'll just end with the data aspect of it all, because I totally agree with Claire about pushing out decision making from the centre into local communities. But what we need to remember in this country is we have a really, really unique organisational, I would say, asset, in the sense that all of that local information can then come back to a core in the centre. There's not many countries in the world that can do that, and that has huge potential for analysis, for policy making, and for research. And I think we're only in the foothills of unlocking that potential, because obviously as Labour government we're rightly obsessed with growth. We see the National Health Service and the health of the nation as a vehicle for growth, but institutionally the NHS has been very poor at selling itself and its value to the world, and I think we need to get more confident and muscular about that, and pulling the data from the periphery into the centre. And I'm not ashamed to say it, to commercialise that data, obviously in a responsible, democratised fashion, is absolutely the direction of travel we should be taking. Because at the moment, the NHS is not the pride of the world, we accept that. But I think when we get this right, you know, we have something really, really fundamental and unique to sell to the world, and I think we should go out and do that.
Brilliant, thank you. That's really interesting. Stephen, do you want to come in with your perspective?
Yeah, so obviously I'm aware I'm the only the least qualified member of the panel, so I'm just going to confine myself to talking about some of the big political issues that have defined the situation the NHS finds itself in. The first being, of course, that for reasons that aren't going to change, the British model of healthcare policy assumes that the government will be responsible for raising all of the money for it, and whether you think it would be desirable if you could to invent time travel, go back and do something more like what the French do, it's not going to happen, right? It's one of the real blind alleys of Conservative Party politics over the last 2 years was this focus on forms of ways you could change the healthcare system, which would first have involved the party doing it, losing every seat in the House of Commons, and being wiped out as a governing force. So, you've sort of got to make something that looks a lot like the NHS work. That's the only politically viable option. However, the distinct challenge that our model of providing free healthcare creates is, like everywhere else in the world, we have an aging population, you have rising healthcare costs, and that means you end up with a state like the one we have now, where we essentially have an NHS that doesn't work very well, and a border force, and other than that, not a whole lot of state. And seeing as the lack of state elsewhere drives so much extra pressure into the NHS, that is a big problem. Now, so there are two, I think, important things that I think the new government is rightly focusing on, capital and management. actually the big difference between the last time you came into office and this time is that the last Conservative government was, by the end, spending about the OECD average on the NHS, which it wasn't in 1997. So there was a more obvious set of NHS fixes in 1997. However, very little of that money goes into capital. As we've seen, NHS England continually ends up raiding its capital budget. A big part of the reform piece, because I know those of you Labour members have perhaps been feeling being slightly beaten over the head with depressing rhetoric. I think I would suggest is if you look at what Rachel was saying yesterday, and indeed some of the other things Cabinet Minister saying, I think if you are someone who is excited by infrastructure, you will find the budget quite exciting. And a big part of what the government will want to do with NHS reform is make sure that when it does spend more on infrastructure, it is actually resulting in more infrastructure, and that isn't in an NHS context just, you know, AI, that is in some cases Windows 7. But the second part, making sure that capital expenditure is management. I'm aware that I'm saying it's right next to a GP, but although the GP model clearly works for some general practitioners, the revealed preference of most people who go into medical school and what they do after shows that being a GP has become less and less attractive, has become a task that fewer and fewer GPs want to do in the traditional GP model. And seeing as so much of our system of allocating and deciding healthcare funding is based on getting the GP to do a bunch of things that many GPs don't want to do, can't find the staff to do, and can't fulfill, there is clearly going to have to be a broader set of thinking about what that means. And I'm sure that you'll have thoughts on what those would be.
Brilliant. That was a really concise summary of some of the most fundamental problems in the NHS, so thank you. Sonia, do you want to come in with your reflections from general practice and from the Fabians?
Hi everyone. So I thought I would start with a case that I guess sort of explains why I spend my annual leave for the past 10 years coming to Labour Party conference. So I was working a shift in A&E, and we had a child who had an asthma attack at home, brought in by ambulance, and we tried to resuscitate him in our A&E department, but he died. And so asthma deaths, they're seen as largely preventable deaths. They're deaths that shouldn't happen. And yet we have one of the highest childhood mortality rates from asthma in Europe. And I can, in the Q&A, I can explain why our asthma death rates are so high in this country. But crucially, when we look at the cases when they have been reviewed, nearly half of the cases were found to have had inadequate NHS care. So I start with this because I think, in many parts of the NHS, we're just not getting the basics right of what good quality care is, and that has to be the first priority of this Labour government, addressing that. Secondly, as others have mentioned, the healthcare needs of our population has changed significantly over the past, and the success of modern medicine is that people are living longer with more chronic conditions, but also, as Claire mentioned, the health expectations of our population has changed. So, if you can get a sofa delivered the next day on your phone, it's frustrating. I think many of my patients find it frustrating how outdated our systems are in the NHS. So I guess first we have to digitalise our NHS. We have to integrate our digital systems, because for my elderly patient that has multiple health needs, for the GP, the physio, the specialist, for these professionals to work together to provide holistic care, then we need to be able to be working on the same IT systems, be able to see what each other are doing rather than working in silos, what happens right now. Secondly, as others have said, I completely agree, we have to invest and expand community care. And yes, you'd expect me to say that as a GP, but actually when we ask our patients, that's what they want. They want their care to be in the community. But this doesn't just mean more GPs. I think we need to be thinking about new models of community care. So how we can have different healthcare professionals, different health services within and outside the NHS, working together to provide well-rounded, holistic care to our patients. So I'll give you just a quick example. So in South London, they had really high musculoskeletal waiting lists. This is waiting musculoskeletal people with joint problems, with back pain, hip pain, joint problems, waiting to see the specialist in the hospital. So what they did was that they worked with the local gyms. They used the facilities in the gyms, the staff in the gyms, the equipment in the gyms. They had NHS specialists and NHS physios go into the gyms to provide the services. And the patients loved it. They loved that they were getting their care in the community. And the results were absolutely phenomenal. Not just improvements in the patient's primary symptoms, but also really amazing improvements in patients' mental health, people like the social aspect of it. So I think we have to be really sort of innovative in thinking about new models of care. And we also don't have to be doing all this thinking ourselves. Like across the country, actually, there's some really amazing things happening, but we need to be sort of identifying those and upscaling those and spreading that learning throughout the country. And then, then finally, I guess bring it back to the case that I mentioned at the start, and what Claire and others have mentioned. The reason why, so I work in Tottenham, and the reason why our childhood hospital admission rates and why our childhood mortality rates are much higher than other parts of the country is because many of my patients are living in houses with damp, they have poor nutrition, they are exposed to high levels of tobacco and air pollution. If you are a child living, that's right, so if you are a child living in deprivation, you're 2.5 times more likely to be admitted to hospital with a breathing problem. So to finish, we have to get the basics right in the NHS of what good quality care looks like. We have to be innovative and ambitious in building new models of care in the community, but we cannot shy away from tackling the drivers of poor health. And here we have to be bold. We need bold action from this government, because the health of our nation is declining, the health of our children is declining, and that's most stark in the poorest parts of this country. So I think a Labour Party, actually Labour in government, that they have a duty to address that.
Brilliant, thank you. So I am going to open up the floor to questions, but I am simultaneously going to abuse my privilege as chair and ask some questions myself. So to come to your point, Stephen and Sonia, about kind of the future of the GP model, particularly in the era of prevention, but also in an era where clearly the partnership model is no longer working and it feels somewhat outdated. I mean, what do you think, and Labour have expressed an interest in moving completely to a salaried model. Do you think this is a good idea? Do you think it's likely? What do you think that would look like on the ground, and what do you think it would look like politically, Stephen?
Well, the thing which is really difficult with healthcare reform is it's the one where what's annoying if you're the Secretary of State for Education is everyone was at school once and we have a lot of vague memories about it. I did this guy chaired this commission 2 years ago, and the number of requests we got to include something on the curriculum was already on the curriculum. But the difference is that means you actually can get away with making quite a lot of changes because people don't lose out immediately, and you do then get the benefit of whatever change you've made. The political challenge is that although I feel often when you talk to people about how they interact with their GP, they describe a relationship which doesn't work for them, makes them very cross, and is taking a lot of time of a highly trained and, from a government policy perspective, very expensive clinician, and making them do a lot of admin. But people think that they like it, and they understandably get very scared and change to it means something like the United States. So I think if the government does want to move to the salary progression, I also I'm very keen to so many things about that. Just from you're the person who have to want the job offer. It has to have a very clear and well communicated vision of what the end of that looks like, so people don't feel that what it means is worse than what they have now.
Yeah, I think that's a really good point. Sonia, what do you think?
Yeah, I think that we have to. The first problem that's going on in primary care is that if we look over the past sort of 10 years of the way funding has happened, primary care fund has been underfunded compared to other parts of the NHS. And the current funding model for general practice doesn't work, particularly if you're a small practice. So I think that's a problem that needs to be addressed initially. So across the country, you're seeing small GPs closing down because they're just not sustainable. So, my area, we've had 2 practices closed down recently. We've had to take over 1 practice, and actually had like a suicide of one of the GP partners in a neighbouring practice because it's just become increasingly unsustainable. So before making any changes, I think we need to have a funding sentiment with general practice. I think you're right in that a lot of time in general practice. And I think this is the problem throughout the NHS, that because we've just been firefighting for the past few years, we're not able to think about how we do things differently. So I think in general practice we spend a lot of time, GPs spending a lot of time doing things that they don't need to do. So I spend hours every day doing admin, like hours, stuff that definitely could be done by other people or could be done automated. But I think because you're so just firefighting every day, trying to get through the end of the day, we've not had the time in the NHS to sort of think, actually, this could be done a bit differently. I think that a crucial problem as well in general practice is that there's too much variation across the country. So, I'd say this, I think my practice is a good practice, but I know that there's some GPs that are not providing good care and there's poor satisfaction from patients. So I think the first thing that I would do if I was Labour government is identify the areas where GPs are underperforming, where they're not, because we have certain markers that you have to meet as general practice. So like you have things like QOFs, which basically show that you are meeting certain demands. So you can quite quickly identify where the practices are underperforming, and then action needs to be taken to either support those GP practices or actually say, actually you're not working, we need to put something else in here. And then shifting from away from the model and to salaried. So there's 2 things to say here. Firstly, most younger GPs are not becoming partners because they see the older GPs who are partners and think, I don't want that life. But I also think you will have a lot of, I think if they did try to shift away from the partner model now, you would have a lot of opposition from GPs, because I think it comes to a trust element from NHS workers, that we don't trust the governments in providing the right conditions. So I don't think it's something that they should be doing immediately, but I think it's something that we should be working towards. But we do need, I think what we need from the government, because we've heard about these things, we've heard about these like neighbourhood health centres, we've heard actually a lot of the stuff that Labour's saying, we've been saying, the other governments have been saying this before as well, actually, like about move to the community, funding community care, move to prevention. So I think we actually need to be seeing what that looks like, and we actually need to see what the policies are and what that looks like and what these new models of care look like to get the buy-in from health workers before you can make quite a big shift in how we provide primary care in this country.
Yeah, that's really interesting. And I think we did a recent piece of work on primary health, some major papers, and a huge theme that came out from all of our conversations with GPs was admin. The administrative burden consistently came up. Some people said it was about 30% of their time, which could be so easily channeled into other people or indeed into automation. But with algorithms, for example, that kind of already exist and are well established.
Yeah, and you hear a lot of criticism like, GPs are all work part-time. It's like, I have my clinics, and then when I'm not working and when I'm not getting paid, I'm doing my admin. Yeah. So I think a lot of people don't realise that how much, for every every clinic you do, you're generating a few hours of admin, which is unpaid and you're doing outside of work.
Yeah, definitely. I mean, Zubir and Claire, to go off Sonia's point about the idea that successive governments have said we're going to move to prevention, what do you think will be different about Labour's approach? Because there is this eternal tension in policy making that you're between firefighting and long-term vision, and there's nowhere that's more true than the NHS. So how do you think it might be different with this government?
So, yeah, I mean, listen, in democracies there's that inherent tension between the short and the long term, okay, because everything directs you towards the short term when you're itching to do the long term. But I think in the current problems we have in the health service, there's a unique opportunity to stitch together the short and long term. Because how we tackle the backlog, how we interact with primary care issues needs to be a portent for the longer term vision of the National Health Service. We have a unique opportunity here to do things quickly and see if they work, patient pathways, different ways of remunerating clinicians. And to pick up a point around GPs and whether they should be salaried or not, I'm not qualified to tell you whether they should be salaried or not, but I can tell you as a clinician, what we value the most is autonomy, is to have a locus of control around our workload, And sometimes what I would say about the salaried model, both in hospital and in general practice, is that it kind of, respects the time spent rather than the activity done. And I think at some point we need to pivot towards focusing on the activity done. That's an overall kind of, a comment on what salaried models do for healthcare workers, particularly at the senior level. In terms of countless governments saying about prevention, I think what's different here is that we are approaching it from a perspective of opening the book of the National Health Service. We're quite transparent in the Darcy review of allowing Lord Darcy into the kind of engine room of NHS England and adumbrating the issues, especially around the capital budget. So that's the first thing. I think this level of transparency that's not happened in the last 2 or 3 decades, certainly. The second thing is I think we've got buy-in from all the stakeholders for once. I think I was reminded in the last Labour government when I was still at medical school and a junior doctor, there was a tension between doctors in that government when they were challenging us to talk about how long people are waiting in A&E, when it seemed impossible that we would ever get to an 18-week wait. There were inherent tensions there. But I think this time round, the appetite from within the health service for radical reform is as great, if not greater, than what government wishes to do. So we're on the same page, and that's been vindicated with all the discussions I've had over the last 48 hours with clinicians who've come to conference, that this is going to be a true partnership, and that's why they're going to be fundamental in informing that 10-year plan that we're going to get started on very shortly.
Great. Thanks. Claire, what do you think?
Yeah, I think it's a fair challenge. I think the things that might be different this time is, I think politically, Labour have to get waiting lists down. Like, they have to get waiting lists down, and they're not going to be able to get waiting lists down unless they make some of these changes, because it's just absolutely apparent you can't. The only other alternative is you put a lot of money into it, and that clearly, in terms of just ameliorating it, is not going to happen. So I think the political imperative to do it is so urgent that it will drive a centrality of this being something they need to deliver on. I think the second thing is, I think Labour need to be quite careful about how much of the sort of structural reform you actually do take on, because you can get then bound into lots of things that aren't actually very outcome orientated. And I was just thinking about like the experience of the kind of the coalition government I was working in, and happened to be working in a government agency at the time, and it was like you were being thrown loads of different structural reforms from every single department, and there wasn't really a massive coherence between how we were doing them in ministeriality as well. But I do think some of that was well intended. Like, it wasn't like it was necessarily coming from a bad place. But if you try and embark on a whole bunch of structural reform because everyone's saying the system's broken, like, you just end up really not achieving anything and create other consequences you don't want. So I don't particularly like having a view about the kind of the GP commissioning model at the moment. All I would say is only do structural reform if it's really, really necessary, and have your eye exactly, as it says, exactly on, like, is this going to produce a better outcome for patients? And if it's not, and it's not clearly evidence to proven, it's probably not worth doing.
Yeah. All really helpful and interesting contributions. Right, I'll now open the floor up to questions. I'll try and be relentlessly disciplined. If you speak too long, I'll hit an imaginary red buzzer and you won't be ejected from the room. No, that's a joke. You won't be ejected from the room. Okay, right, I'll take 3 at a time. If you can have the mic here, and then Richard, and then the gentleman.
Thanks everyone for your speeches today. I work in the field of robotic assisted surgery, and which is a great example of moving from scalpel to a robot. Seems to me a great example of analog to digital. I just wondered, with so much needing to happen, and we're seeing these 3 shifts which kind of are almost sound bites at the moment, but underneath it is so much work. I wondered, on the analog to digital shift, the panellists' realistic assessment of how achievable that is at an industrial scale. Thank you.
Great question. Richard?
Yeah, hi everyone. Richard, Sonia, former Special Advisor, Department of Health. My question is on public health. And Zubir, you made a really interesting point about Darcy and transparency. If you play transparency through into the second Darcy piece with the IPPR on health inequalities, the level of action you would take to address that in public health would be fairly significant through the mission board in places like obesity, alcohol, clean air, physical activity. How up for significant public health action do you think this government is, particularly from a state regulatory perspective?
Brilliant, another good question, thanks Richard, and yeah, the gentleman behind him.
Hi, I'm Paul Farmer from Age UK. Through the lens of older people, but much more broadly than this, I'm keen to understand what the panel thinks about cross-governmental approach to the mission, because a lot of you have already mentioned the need for much greater join up. This isn't about the NHS, it's actually about what all the rest of us do, and including other government departments. So how do you see that really working? And as a complement to that, where do you see the role of the voluntary sector, both from a provision point of view, but actually just echoing Richard's point about prevention, when probably some of the best campaigns of the last 20 years have been driven and led by voluntary organisations, be it British Heart Foundation on smoking, my previous organisation Mind on mental health. How do we really embed the role that voluntary organisations can play in being a part of that mission? Thanks.
Yeah, a lot of really good questions there. So Zubir, I'll come to you first on the analogue to digital shift and on robotic surgery as well. I mean, robotics is actually super interesting. We wrote a briefing on this because it massively reduces recovery time in hospital and can really help with bed occupancy issues. But like, how plausible do you think the analogue to digital piece is?
It's absolutely essential, because we're already working to a kind of minus 20-year process. So we've got to do it quickly. It has to be done at an industrial scale. There's two pieces of it. One is obviously things like robotic surgery and all the rest of it. We can't remember the robot's operated by a surgeon, so there's still the human individual is still doing the surgery. So this is just another tool for the surgeon. So we still need surgeons and clinicians in that respect. But for me, the analog to digital piece is actually as much as possible about automation of process, because modern healthcare generates exponentially more data points per patient per day than even it did 5 or 10 years ago, and we simply do not have a digital spine to cope with it, and that's why it falls on the human beings to do all of the processing, as you know, mostly in primary care with poor folks like Sonia having to do it. So we've got to grasp that nettle hard and strong and grip it, and use that as the centrality of the focus of the digital revolution, because we can literally free up millions of hours of clinician time if we get that right, and that is simply a prize that we must have. That's what I'll say about that. Do you want to comment on other two?
Yeah, go ahead.
We are definitely up for public health actions. So obviously we can be accused of being a nannying state by certain parts of the media or certain political groups. What I would call it is just a recalibration of the choice spectrum, because at the moment a lot of choices people are making about what they eat and how they eat and where they go. It's not free choice. They're being nudged into certain types of diet because they're cheaper, and they're cheaper and more unhealthy, in fact more calorific, and will have a greater propensity to store fat and cause obesity. So from that perspective, we're having conversations, and it's in our manifesto. We're committed to those manifesto pledges, particularly around child health, around energy drinks, advertising for fast food, targeting children, and of course our piece on the smoking outdoors is still on the table. So we're absolutely up for public health reform. In terms of cross-governmental working for the mission, so Peter Kyle and Wes Scooting, it's not an accident that they have their offices next door to each other, okay? Because they value the inextricable link between science and innovation and the National Health Service as a growth tool for our economy.
Great, thank you. Clara, I'll come to you on the public health question, but also the cross-governmental approach. I suppose public health as a political question is quite interesting, particularly on smoking, like whether you think smoking or obesity, whatever. 20% of the country smoke, 60% drink alcohol, 100% of them obviously eat. So sometimes you might take one hit on a public health intervention, but you say it's worth it because much less of the population do it. So how did you find working on it, particularly like you said, Starmer's speech on prevention a few years ago with Fabian? How did you find the kind of public health framing, particularly from a political perspective?
I think think agree. Like you can see, there's obviously clearly like an appetite from this government to kind of grasp some of these issues that government successfully have kind of dodged around. Although obviously the action that the last Labour government took on smoking has been transformational and had lots of opposition, but also had lots of campaigners, etc. So that like they have got some good form on it. And I think part of it is getting the balance right between taking firm action where we know there is clearly a detriment to public health, and I totally agree on the kind of food industry that on the whole that has been dodged around. I also think that you've got to balance that up with the statement that Keir said in his speech about a government that treads lightly on people's lives. I think that Labour will win a lot of support for taking action to, for example, support parents whose kids have bought those energy drinks and nobody ever asked their age and those sorts of things. Like there's lots of support for those sorts of things. I think you have to tread a little bit more carefully on things that are stopping people doing the thing they think is a free choice to do. So I think there is a big spectrum of things you can do on regulation. My general thought would be go with the grain of the way individuals want to behave and encourage them to do that and take action on companies to support them. But on the whole, where you're confronting individuals with that choice, they are on the whole not the ones that have got the problem here. The problem has been that they have been exploited, I think, by a sort of profit model which has helped us all to be unhealthier. So I think there's a distinction to be made there. In terms of kind of the cross-government approach and a bit about the kind of the role of the voluntary sector as well, like I think the more of this that can be done at a sort of, I'd call like a place-based level, but at the local level, the better. Because you have a commitment from the politicians, the local employers, businesses, community organisations, the community itself, on the whole, to their place over time. Like they want to have healthier places that are more productive, that are more prosperous. They tend to take a lot of the party politics out of it a lot of the time as well. So I think I'm interested to see what happens with the kind of cross-government mission boards. I think we are out of the days where you can drive all this stuff centrally anyway. And therefore I think the trick is going to be in getting this right is having a national government that knows how to set the right framework, but also releases control locally so that people come up with a really long-term plan on a lot of this and involve the private sector as well as the voluntary sector too. Like businesses and employers want to have healthy and productive citizens, they want a well workforce, they are not the enemy here. There should be a sort of place-based approach to it, and I think that is the most exciting bit actually of what Labour's doing.
Yeah, definitely. I think that's sort of, we wrote a paper a few months ago about devolving the NHS was very heavily based on that premise of kind of empowering local decision makers and bringing them all together in a more coherent manner. I mean, Sonia, on the ground, with the voluntary sector in particular, they play a huge role in the delivery of a lot of kind of primary community services, especially drug and alcohol services, for example. A large majority of them are actually done by charities. How do you find working with them as a GP? Like, often GPs say that it's not interconnected enough, the systems aren't interoperable, so you can't always see what's going on. Like, what does it look like on the ground?
Yeah, I think there was I think it's useful, but I think I guess we work less with voluntary services, but we do work a lot with council services. But I think the problem with a lot of these services is the short-term funding arrangements that they have. So we'll have a great service that's there providing good service for like a year or so, or a few years, and then they lose their funding, so they disappear, and then another service comes up, and often in general practice you just don't know what services are available in the area.
Yeah.
So often I'm like, I'll find out about services, just randomly find them out, but there isn't a good enough structure to know what is available, and those services aren't working together properly. And we do have social prescribers have come into general practice in the past few years, so they're really useful. So we hire someone that their role is essentially to link up our patients with voluntary services. So that is happening, but I think there needs to be more of a structure to that. And also some things we can't rely on the voluntary sector to do. So drug and alcohol services, for example, we had a really good NHS drug and alcohol service with GP working there, and then it lost its funding. So then in the area it lost its funding, so that service collapsed. Voluntary services took over. But we then in the years after that, we saw our deaths from alcohol and drug overdose increase significantly. So some things do need to be done properly and do need to be done funded properly, but I do think, yes, there is a role for the voluntary sector, but it needs to be connected properly and funded properly and have long-term funding settings for that.
Yeah.
And then to your question about sort of public health, yeah, I agree with everyone what they've said. A third of our children are overweight or obese. So that's their health, that's not just impacting their health now, but it means that they're going to have significantly poorer health and more at risk of premature death later on in life. So it needs to be addressed. And we live in an obesogenic environment, so it's very easy to put on weight in this kind of environment. It's very difficult to lose weight. And healthy living is expensive. So if you were to follow the NHS England's healthy living guidelines, and if you are in the poorest 10% of the population, you'd be spending 75% of your disposable income just on food. So it's completely unaffordable. So we need to be making our food better quality, and healthy food needs to be made cheaper. And I also think we need to be thinking about how we make our population more active. So if you look at comparable countries, I think there's sort of 17 sort of European countries, we rank, I think, 14 out of 17 for our activity levels. So we're really bottom of the list when it comes to activity levels. And there was a country, I think it was Denmark, that was also very low down on the list, and then they set themselves a policy agenda that we're going to make ourselves the most active country in Europe. And I think in the space of about 5 years they managed to do that. But it was with, as Paul said, it was a cross-government thing, cross-government policy agenda to make their population more active. So I think we definitely can do that, and it has to be cross-government, it can't just be in the NHS, but how we make our population healthier, more active, better food, and of course that's better for everyone, but also that will save our NHS money. Because as Claire said, so many of my patients have health conditions and have poor health, and it's preventable health conditions, and it's because they have. And yes, we can. I think often in prevention, I think we get the word. Sometimes we use prevention in an incorrect way. I think in the NHS we often use prevention as doing more blood pressure checks, doing more cholesterol checks. That's not prevention. That's just picking things up early. Prevention is actually stopping people from getting those conditions in the first place, and that needs to work outside of the NHS.
Yeah, definitely. I think it was really important drawing attention to the perennial issue in the NHS of single-year funding settlements. That Stephen rightfully drew attention to spending, but I don't think people often realise that how that money is spent and where it goes to in the system is fundamentally flawed and undermines the efficiency of the services quite substantially. Okay, we've got time for 3 more quick questions. Oh, yeah, right here. Thanks. Yeah.
Janie Mulaney, I work for New Market Strategy, which is the life sciences consultancy. We've spoken a lot about child health problems, especially what you just said, Sonia, about obesity and also the really sad asthma deaths. But I just want to touch on child mental health. I know that Labour have signalled some changes to supporting better mental health among children in their Child Health Action Plan. But I just wondered if anyone could expand more about how Labour might be able to be bolder in supporting child's mental health, and how Wes's 3 big shifts, analogue to digital, hospital to community and treatment to prevention, can be applied here to support the provision of mental health services for younger people.
Great, excellent question. Any other questions? Oh, yeah, Charlie and Kate, yeah.
I'll take one anyway.
Go on. I thought Stephen made a really important point in your opening remarks about the fact that despite us wanting to see the shift towards primary care and community care, we're not attracting people into being GPs. And actually, if we can't solve that, then there's no way we can make the shift. And very little of the workforce conversation is actually based on okay, but we don't want to keep specialising in acute systems because we're saying we don't want to drive people there. We actually want more people out doing the preventative general practice type work and other kind of health professionals around it. And I just wondered whether people had views on how you actually get people who are coming into wanting to be doctors, wanting to be GPs, and not wanting to be a highly specialised acute sector doctor.
Great question. And then Kate, do you want to come with our final one?
Thank you. I'm Kate Arbu. I'm the former Director of Public Health for Wigan. So I've been very interested in hearing some of the conversations. And Claire, I think you and I know each other previously. I'm one of the team who put together the Wigan deal, so very much a place-based approach to public health. And by the way, Zubir and Sonia, I am also a medic as well.
My question is about total place, and I guess just listening to the conversation about funding, total place is coming back into the thinking, particularly around devolution. Claire's point about devolving health budgets to a place-based level is actually really important if you want upstream shift of money into prevention. I know that because we did that through a section, not a section 1A, but a section 57 agreement around the way in which we spent NHS revenue and council budgets. What's the panel's view about devolving the entire NHS revenue budget to a place-based approach and linking it to the financial settlement for local government? And by the way, Sonia, the reason your drug and alcohol services were getting single-year funding was because of the late announcement every year since 2013 of the public health grant.
Yeah, great question. And drawing on a recommendation from a previous report where we recommend devolving all funding to local government and regions.
Which
so,
I advise.
Exactly. So let's touch on child mental health really. Yeah, because we haven't spoken about mental health too much on the panel. Who wants to come in on that? Yeah?
I mean, probably like a longer answer than we can give now, but like I actually think Labour have been really bold about child's mental health, and I think if you think about the few spending pledges that Labour did make in opposition, mental health was like the totemic pledge at like the 2021 conference, and that had come out of a piece of work that we'd done called Recovery and Rebuild internally, which was about what happened in the pandemic, and therefore I actually think Labour put children's mental health and the mental health of the nation really, really centrally in terms of their health priorities, and in a sense that was to illustrate what we meant by prevention, which was there are lots and lots of people that shouldn't need to get to the acute position that they are in if we are giving the right sort of support further upstream. So I think it was a sort of a totemic pledge, and I look forward to seeing that be developed in government. But I also think it connects to the wider point we've been saying all the way through, which is around how does this sit within an overall healthier society that is support for parents, because actually supporting parents with some of these decisions, whether it's about what they're exposed to online, whether it's about outdoor places to play, like there are lots and lots of ways that we don't even have to go near what is the crisis in CAMS to talk about how we can support parents and support children and young people. So there's huge amounts to say about that, but I would say that you can't do this just at the acute end. It has got to be done in our sort of wider societal approach, and I am genuinely optimistic that I think that is what the Labour team have got in their line of sight. I think it's very difficult to involve budgets because of the democratic accountability, and I think it is actually really, and I would want there to be more that is done at a devolved level, but ultimately I really want people to have a say, and I think that matters for us as voters. But I also finally would say that a lot of this, I think, is about people having as much control over their lives as possible, and not feeling like they're being told or done to, but they're being encouraged to take the steps that they need. That is where our well-being is best, is where we are in the driving seat of our own lives. So yeah, just very encouraging us to think about citizens, us all in our lives, that our health starts with us, and all of this around it is just stuff that can point us in the right direction or the wrong direction.
Thanks, Claire. And very quickly on Charlie's question about GP attracting people to GPs. I mean, it's a good question. I mean, why are people so attracted to secondary care in general, not just GPs, nurses as well? Do you want to come in on that, Zubir?
So when I started medical school in 1999, last century, so 70% of my cohort wanted to be general practitioners. So it's something that's changed quite fundamentally in a very short space of time, and it just goes back to the incentivization model. If you remember why those people wanted to be GPs, they liked the generalist aspect of work, that no 2 days were the same. They liked the idea there was a locus of control over their workload. They liked the idea that they got to know their patients and their families and provide that, dare I say it, cradle to grave service. Those are all things that modern healthcare, modern society needs, and in fact it demands. So those things need to be constructed and incentivized. So I think it's an incentivization model really. You know, and that's where I fundamentally believe, you know, you get the best out of senior clinicians when you give them more autonomy. Of course, you hold their feet to the fire with the right KPIs and all the rest of it, but you've got to release them to do their work, and you've got to give them the autonomy and the headspace. And I think when we're looking at general practice, I think those are the two paradigms and the principles that should guide us into whatever new model that we're heading into. And it's still going to be a mixture of salary and other structures, but it's quite striking in Darcy's report that the most economically efficient part of the health service is primary care and GPs, because they're forced to be efficient. But also they're forced to be efficient because they've usually got skin in the game. That's what partnerships offer. It offers them to have, you know, skin in the game and be fundamentally involved in the processes that shape their healthcare delivery. I'm just going to make a small point about mental health if I can as well, because in some ways child mental health really encapsulates our principles around prevention and about the National Health Service being a national growth service. Because if you're a 14, 15-year-old suffering from anxiety, there's real sliding doors moment there if you're old enough again, like me, to remember that film. You know, you can go down the pathway of a waiting list, hanging around, waiting for a specialist, or you can go down the pathway of quick and cheap, relatively cheap, CBT treatment to treat that anxiety over a course of, you know, a number of weeks or months. And that decision right there will determine whether that child then becomes an 18, 19-year-old adult that takes up an apprenticeship, goes on to further education, lives a, you know, kind of a satisfying, healthy, economically active life, or whether perhaps that child then becomes that adult that needs more of the state support financially and otherwise, and doesn't contribute to the economy, and then lives a less satisfying life. So in some ways, cracking, you know, child mental health is in some ways the portend for how we're going to function as a society and economy for the next 10 and 20 years.
Yeah, I agree with that, and it's a really good note to end the panel on. Thank you so much. I'd love to continue this conversation, trust me, but unfortunately we are bound by time, and your time as well, of course. So thank you everybody so much for coming, and I've really enjoyed it, and I hope you did too.